Richard M Rosenfeld, MD, MPH, MBA, and I am a distinguished professor of otolaryngology, past department chair at SUNY Downstate, State University of New York, Downstate Health Systems University, which is in Brooklyn, New York, and the director of quality and guidelines for the American College of Lifestyle Medicine. Well, we've got hundreds of guidelines, so one would think there aren't any unmet needs, yet despite hundreds of guidelines, we seem to be having an epidemic of type 2 diabetes. Over half the population has either prediabetes or full-blown type 2 diabetes. So as they say, Houston, there's a problem. And I think the problem is that despite all this great advice and better medications and obviously the new GLP-1 inhibitors, we've sort of danced around the fundamental problem is that type 2 diabetes is fundamentally a disease, a condition related to lifestyle. And guidelines do often have lifestyle statements. They'll say, eat better, eat healthy, low carb, high carb, less fats, get some exercise, get a little sleep. But it's sort of second fiddle to the main message of monitor your glucose, take your meds, get your therapy. So the unmet need is to bring lifestyle to the forefront in managing and preventing type 2 diabetes, which is an incredibly empowering message that people have the ability to overcome their genetics through lifestyle, to put diabetes into full remission with lifestyle, get off all medications, glucose-lowering medications. So it's really a exciting and I think important message that clearly fills an unmet need. Exactly. So lifestyle medicine came about 20 years ago is when the American College was founded. And it's always had 6 pillars of focus: plant predominant nutrition, adequate physical activity, getting some restful and restorative sleep, stress reduction, connectedness and social connections, and then avoiding risky substances like smoking, alcohol, etc. But really, what's important is that those pillars are sandwiched in the guideline between a few recommendations up front and behind. So before we even get into discussing the pillars, we make some statements about how clinicians and healthcare professionals really should just advocate for lifestyle medicine. Let patients know the power of this, stress its importance. That's a full recommendation. And then it deals with seeing where the patient or the person is at their baseline in terms of what is their lifestyle, where are the areas for potential improvement, and last, looking at readiness to change. Some people are more ready than others and more committed. We then get into the 6 pillars and end with strategies for sustaining behavior change, monitoring outcomes, and importantly, deprescribing, because often a lot of these changes will result in a need for less medication. So to keep it as simple as possible, and I would certainly encourage people to look at the guideline, which is rather large. It's 120 plus pages, but there are about 30 illustrations and implementation aids and many tables. And if your attention span is limited, we have an executive summary. We also have a plain language version, especially for patients, consumers, the public. So lots of tools. But, starting with plant predominant nutrition, we emphasize a whole food, plant-based diet, but we're not telling people to be vegans or vegetarians. We're saying to eat the right stuff. We do not recommend a lot of these low-carb approaches, which may have some short-term benefits, but long-term problems, or keto approaches. And we're very facilitative in our advice, meaning we want to promote a healthy eating pattern that is plant predominant, but it has to be tailored to the cultural and needs and the goals of the individual. Some people just want to get off their meds or at least reduce their medications and feel better. Others want complete remission, and the approaches are different as outlined in the guidelines. So we're very explicit with that. In terms of physical activity, it's getting the minimum 150 to 300 minutes a week of moderate activity that are recommended in the US guidelines, 2 sessions of some resistance or strength training. And we talk about how it can really help with your glycemic management, make you healthy, avoid complications, and really the combination of nutrition and physical activity is very potent in managing diabetes and preventing progression of prediabetes or gestational diabetes. Regarding sleep, we talk about the importance of regular sleep with some strategies. There are certain sleep syndromes. For example, obstructive sleep apnea is very common in people with diabetes, so to be vigilant for that. We do manage general stress reduction. We discuss that, but also talk about more significant conditions that are prevalent in individuals with diabetes, anxiety disorders, depression, diabetes depression. These things really need to be sought after and managed. And if you don't look, you don't find. With connectedness, social connections, we emphasize the importance of family support, peer support, professional support, networks to help sustain and maintain behavior change and really provide the support people need to succeed. With regards to substances, we talk about limiting alcohol. You don't have to abstain completely, but there are some reasonable limits. Smoking, of course, is very bad for people with diabetes, as is recreational marijuana. So those are the 6 pillars, and there's a lot of detail, but they fit together. And in most guidelines on diabetes, they talk about nutrition and physical activity, but the other pillars don't get the same attention. So we've really tried to balance that out, and that's another, I think, unmet need of the guideline. I think it begins with the first, what we call key action statement, which is asking the clinician or healthcare professional to advocate for lifestyle interventions as a core principle in managing and preventing diabetes. It's not done often. It's almost like the 1960s when the Surgeon General said, don't smoke. And did doctors promote that message or the AMA? No, it took time, largely because all the doctors were smoking at the time, and many were in ads advertising cigarettes. So nowadays, where very few doctors maintain a healthy lifestyle, they're often overweight, obese, some still smoke, they don't get enough activity, they're busy. Are these the folks who are going to embrace lifestyle change for their patients when they haven't embraced it for themselves? Probably not. So I think that advocacy part is really important up front, and we provide some handouts and tools to do that. And then seeing where the patient stands with an inventory of lifestyle, and we have tools for that. The pillars are all important, but I think the last thing is really promoting and sustaining change. A lot of people will change and embark on a mission, but if you don't provide them with the peer support, the coaching, the systems to help them sustain and maintain change, it's all for naught. So I think a lot of parts deserve emphasis, but those are the key ones I would highlight. The key message is that of empowerment. Patients and clinicians can beat diabetes with lifestyle. Plain and simple, regardless of your genetic background, your cultural circumstances, your socioeconomic status, lifestyle front and center. That's the message.